Okay, so hello, my name's Alvin, and thank you very much for coming to this webinar on death certification. Um, for some of you who have tuned in to the previous lectures, thank you very much. But for those who haven't, this is a webinar 6 out of our Medicolegal teaching series that we've been doing over the last 2 months. So thank you very much for joining. So just a little bit about myself. So my name's Alvin. I currently work at the North Middlesex as a senior house officer, as well as in acute medicine, but also on the side, I do this at Mind the Bleep. So also the lead at Mind the Bleep for the medical legal section as well. Have a background in healthcare ethics and law that I did for my intercalation, so was very keen on getting this series started so that we can spread the information to, well, you guys watching. So what I'd like to do is, so let me test this out first. So let's share screen. Oh, so actually, no, we'll go through ground rules in a sec. Just one sec. So select screen. Screen. Okay, I'm just going to turn my camera off so we don't have any distractions. Okay, lovely. Can everyone see what I'm sharing at the moment? If you can, just post in the YouTube live and I will try and have I'll have a look. Okay, so a couple of things. So as always, I want to go through some ground rules. So if you have any questions, please post in the YouTube live section and I will try my best to answer any questions when we have a break. As well as, if you have, the certificates as well. If you scan the QR code that we provide at the end, you'll be able to provide any feedback, as well as on completion of that, you'll be able to get a certificate. Anyway, just want to check, can everyone see? I'm just going to check on Lovely. Okay, so thank you very much for coming to our webinar on death certification. So, as always with any of these lectures, we need to provide a legal disclaimer. So, the information included in this webinar is for educational purposes only. The information included in this webinar is up to date to the best of our knowledge. And should you require further independent legal advice, please seek a professional legal opinion. Essentially, if you are in any legal trouble or do need professional advice, do not use this lecture as a basis for being informed. Okay, so to start, let's go through some learning objectives. So, following this lecture, I hope that you'd understand, or you will understand, the historical and legal framework underpinning death certification in the UK, as well as understand the recent legal and formatting changes in completing MCCD, so the death certification. Identify circumstances that require referral to the coroner. Accurately complete the medical certificate cause of death. And to recognize and avoid common errors in death certification. So, a couple of things. I know this is quite text heavy, but it's important that we get a bunch of the terminology out of the way as well, just so that it's easier for when you listen in later. So, a medical practitioner is a qualified medical practitioner who holds a valid registration from the GMC and a license to practice in accordance with the Medical Act 1983. So, in this case, as well as most of our watchers, this would apply as long as you're applying for your GMC license year on year. Specifically, the medical examiner who I'm sure you may have come across in the last year through your work, is a senior medical practitioner, often a consultant, sometimes solely a medical examiner, or does some medical examiner work on the side. Is employed by an NHS body to provide independent scrutiny as to the cause of death. The informant is someone who meets the legal criteria to register the death with the registrar. So that is usually someone who is close to the member who has passed away, so often a relative or a close member within the family. Specifically the registrar, I should probably reverse that order actually. When I say registrar, it's actually referring to the registrar of births, deaths and marriages. Importantly, the attending practitioner, so this will be specific to us. So that's the medical practitioner who's cared for the patient, is familiar with the patient's history. So this might be the medical history, investigations, as well as any treatment they may have had. And lastly, the coroner is a government or judicial official who is able to conduct inquests and so on into the cause of death or the nature of death. Okay. So importantly, if you don't, following on from the first point, if you don't have a GMC license, you cannot sign a MCCD, otherwise it is invalid. Okay, so we're going to touch upon some of the legal frameworks surrounding death certification. I promise you it's going to be very brief with the first four. So the Births and Deaths Registration Act 1953, that essentially provides the framework within which in the England and Wales we have to report it with, complete a registration of death within 5 days. That is extended slightly in Scotland to 8 days. The Coroners and Justice Act 2009, as well as the Notification of Death Regulation 2019, that we will touch upon later on, essentially outlines what and what should not be referred to the coroner and what processes that may follow. The cremation regulations, England and Wales, that sets out additional details on if the body is to be cremated or not. The Human Tissues Act, that actually looks into how the cadavers should be utilised in post-mortems and so on. So legislation regarding that is included within the Human Tissues Act. Now, importantly, what we will be discussing for the majority of this webinar is the Medical Certificate of Cause of Death Regulations 2024 that came into focus or came into action last year in September. Okay. So, as always with the lectures, some context to the legislative change. So what actually pushed for those 2024 legislative changes? So interestingly, this actually has been a work in progress over the last 20 years. So I think there were plans around 2018 to try and produce some reform. However, this is unfortunately stymied by the COVID pandemic. And thus we now have the legislation in 2024. So there were 4 main inquiries that some of you who may have been reading the news over the last few decades, well, let's say decade, may be aware of. So that's the Shipman inquiry, the Mid-Staff's report, the Morecambe Bay investigation, and Gosport. Just for context, let's go through each of those. So the Shipman inquiry obviously follows Dr. Harold Shipman and focused in on the regulation of controlled drugs relating to the patients that Dr. Shipman murdered. The inquiry essentially found serious flaws on how doctors were monitored, how prescribing was monitored, as well as how death certification was monitored as well. And it highlighted how inadequate reporting surveillance systems were, essentially recommended stronger safeguards. And this was the initial sort of movement to try and get a more robust framework for reporting and completing death certificates. If anyone remembers MidStaff, so that was that essentially looked at the systemic failings at Mid Staffordshire NHS Foundation Trust, where there were multiple instances of poor care and sometimes patient death. And it unfortunately identified a culture of prioritizing targets over patient care, and exposed rather weak management. Once again, essentially advocated the need for more robust safeguarding. So that added on to the Shipman Inquiry in terms of necessity for these structures. Morecambe Bay, so that was regarding some maternity services in the University Hospitals of Morecambe Bay. Essentially found that there was incompetence, poor teamwork between doctors and other clinical staff that led to, unfortunately, avoidable deaths of mothers and babies. Putting it very simply, the outcome of that was to try and provide better leadership and transparency. And once again, more robust frameworks on the death certification. Now, Gosport is quite a while ago, but there was a learning from Gosport was produced in 2018 about the systemic failures then. And essentially, people were being inappropriately prescribed opioids, and it found that many deaths were associated with inattention to family concerns and inappropriate whistleblowing mechanisms. Okay, so moving on. So, a summary of the legislative change. So I've summarized it all relatively nicely. I hope that's legible to you guys. So the main 2 points, or the main 2 subsections following the 2024 guidance change, is essentially who can complete the medical examiner, or the MCCD. So it's now mandatory for all deaths to be reviewed by the medical examiner or the coroner. So essentially, if you aren't going to be reporting it to the coroner, it must be discussed with the medical examiner. Whilst previously we would just complete the death certificate and sometimes get a call to omit that, often we would be able to send the certificate straight to the registry. Now that's not the case. Specifically, they've expanded who can certify the death of the deceased by saying that anyone who has seen, so previously it was anyone who had attended, any attending physician or medical practitioner that had seen the patient or the deceased within a 28-day period. But now they've got rid of that, so it's anyone who's seen the patient within their lifetime. So that has the added benefit of increasing the number of doctors that are eligible to sign the MCCD. So in a hospital, it's not as much of a problem because there are multiple clinicians that see patients day to day. However, in primary care, for example, sometimes patients pass without seeing a doctor in their last 28 days. So this will provide some relief to primary care practitioners. So moving on to the structure. So that's one of the more important things, as some of you may have witnessed. Some of it, F1's coming, maybe not, but the forms are now very different, now double-sided, that I unfortunately made a mistake on the first time I actually completed an MCCD. So I'm sure some of you may have as well. So there's now a new MCCD for deaths that occur after 28 days. as well as a new MCCD for neonates whose death occur after birth within 28 days. Importantly, ethnicity, pregnancy status is now included as well as so ethnicity, pregnancy status, and medical devices is now a section that must be completed on the MCCD. Section 1D, so previously it was 1A, 1B, 1C, so condition leading to, and condition that caused death. The reason why 1D has been brought up in is to align ourselves with the WHO standards. Lastly, the cremation for form has been made obsolete as well, so we do not need to complete the crem forms. So the ethos behind all of this is that it provides a unified approach with safeguards. So it now has all the information that the medical examiner and potentially the coroner may need, as well as the informant may need for any future processes. Yeah, just a little so sometimes you may see people referring to the death certificates as APC1 and APC2. The APC1 is for people that die after the first 28 days of life. The APC2 is for, well, the one that we alluded to earlier, the one where for children or neonates that die within 28 days. So, what is the purpose of death certification? So, firstly, it's very much a legal document. So, by the death being registered, we provide a permanent legal record of the death as well as the medical cause of death. This permits the informant to take steps to arrange disposal of the body, as well as legal proceedings such as settling estates and so on and so on and so on. As discussed earlier, this must be completed within 5 days in England and Wales and 8 days in Scotland. And essentially prompt certification of death means that the process all runs smoothly, as well as the informant can essentially buy a copy of the death certificate or get a copy of the death certificate. This is especially important, so an accurate medical record, not only for the patient, but for the informant as well. So to a certain, depending on the family member the informant is, the exact cause of death, as well as contributing factors, may be very important medical information to themselves. And moving on to public health data. So this is not as immediate, but all information that is inserted into the medical, into the death certificate is utilized for monitoring the health of the population, monitoring as well as surveillance for epidemics and so on. So it can also recognize, interventions and how effective interventions have been. So during the COVID crisis, COVID was very much going on as a contributing factor, sometimes a causative factor of death. And by monitoring death certificates, we were able to monitor how public health interventions were going. So just to summarize, it's a legal document, must be completed quickly to provide medical information to patient as well as family. It's important for public health and for getting due legal process through. Okay, so next slide. Okay, so the role of the attending practitioner. So we touched upon who the attending practitioner was earlier. So that's anyone any medical practitioner holding a GMC license that has taken care of the patient in their lifetime. So Importantly, you must have access to the medical records. So by having access to the medical records, you can complete the death certificate to the best of your knowledge and belief, and refer that to the coroner as required. Now, it's important, if there are multiple people that could be the attending practitioner, as you find sometimes in a hospital, so there are multiple people that may have varying degrees of knowledge of the medical history, investigations, and management, to delegate to those that have seen them on a more regular basis. For example, or is more logistically appropriate as well. So examples I've come across in the hospital is often you may have been handed over jobs to the out of hours. You complete, let's say, you check the blood sugar and it's all normal. You provide a little note. When the medical examiner looks through, they will see your name and see that you have essentially reviewed the patient, but you may not know their medical history, investigations, and management as well. Thus, if there's anyone more appropriate, it should be referred to that patient. Now, it's important to delegate this to the most appropriate, and where there cannot be found an appropriate junior medical practitioner that can complete the MCCD, it must be escalated to the consultant, as they have the overarching responsibility over the patient, as well as the certification of death. Importantly, I guess not as common in hospitals, if you cannot find a attending physician within time, so sometimes they may be on holiday, or they may be on holiday, maybe on bereavement leave, they may be away for some reason. If they cannot attend in an appropriate time, so usually within 5 days, then this must go to the coroner as well. We will discuss specific cases that need to go to the coroner later on in the webinar, sorry. So the medical examiner. So we touched upon this. So this is the senior medical practitioner, often a consultant who works full-time or part-time. So essentially the medical examiner scrutinizes every case that so MCCD that is written by the attending medical practitioner or attending practitioner, as well as all deaths that are not investigated by the coroner. So sometimes you may refer to the coroner, but if they do not think it's an appropriate referral, they then send it back to the medical examiner. So they have workload coming from both sides. So essentially whoops, that's mine. Sorry, just 1 second. We'll try. Sorry about that. See if I can turn that off. I didn't think about that. Notifications, do not show notifications. Lovely. Okay, let's see if that works. So, independent review of all non-coronial deaths. So, likewise with the attending practitioner, they check the medical records and the proposed cause of death. So they will look at what you've put in 1A, B, C, D, and 2, and in line with the government guidance of completing MCCDs, will provide any feedback. Importantly, so whereas you may have had some communications with the family, so the bereaved family, is now the medical examiner's role very much to speak to the family and provide the communication, as well as the conversation regarding the cause of death, and allow them to raise any concerns that they may have had. There we go. Perfect. That won't happen. So they're also the central person that confirms the cause of death and liaises with the coroner as well as the registrar. Okay. So let me fit that perfectly on. Okay, so I think we can all see. So I think it's important that we go through the new structure of the MCCD. I think it would be very much lacking in context if we don't. So has the various acts on the top left that dictate the MCCD completion. There's also some practical guidance on the top right on how to complete it. So if you are ever stuck, please go to the government website, or if there is a medical examiner near you, speak to them because they will be your most helpful person in the scenario. So ensure that you write legibly the name of the deceased, date of birth. The NHS number is new, and you must state exactly where the place of death and the date of death was as well. So, as we discussed earlier, so we have a 1ABC that's the same as what we had before, but in line with the WHO guidance, we've now added 1D. So, what's important to note is that the last line, so 1D, must show, so everything above 1D must have resulted as a consequence of that condition. It's important, so moving along to the right-hand side, so the approximate interval between onset and death. Whereas practically, it's slightly more difficult, so highlighting exactly when the interval was between all 1, A, B, C, D, and 2, you must practically, where possible, complete this. For example, a stroke that happened 1 week ago is more significant to consider than a stroke that happened 12 months ago, for example. So duration does actually matter, but it's where practically possible. Okay, so don't fret too much. Okay, so the section underneath, so circle the appropriate digit for the regarding the post-mortem. In most cases, a post-mortem will not be held. But if there has been any discussion with the coroner and there has been agreement that potentially a post-mortem is appropriate, please circle the appropriate number. The next square is new. So this is the section about patient being pregnant. So where 0, not applicable, is where the patient could not have possibly been pregnant. So someone who's gone under a hysterectomy or has gone through menopause and so on and so on. Not pregnant is where you have some evidence, so whether that be a urine dip or a serum HCG. An unknown is where the patient has capacity to become pregnant, but it was not known whether they were pregnant or not. And did the pregnancy contribute to the death? Yes, no, unknown. That's pretty self-explanatory. Once again, to provide more information to the medical examiner, anything that contributed from employment. So, I mean, the classic one we think about is asbestosis or asbestos that can contribute to lung disease. You can input that information there and tick the box whether you're happy to provide any further information on this or not. So the back half, first time you do it, make sure you look. I'm sure the medical examiner will highlight this if you do forget. So ethnicity is a new section. Usually the documents that the medical examiner or department give you on their paper notes or their admission notes will have their ethnicity on. If you can't find it, don't worry about it. You can put not known. Okay. Now, importantly, medical devices. So this has become a more important feature. So previously you would go down to the cadaver and just have a quick look and just have a look at some imaging, but this time you need to have extensively looked through the medical record as well as any imaging to check whether there is any implantable device. And if you omit this section or fill it out incorrectly, it can lead to inevitable delay, as well as it can actually lead to harm as well. So implantable medical devices in a furnace will result in, well, sometimes, well, explosion and harm. So self-explanatory, full name. You need to put your qualifications, and you need to know you need to put that exactly how your university would give it. So not all medical schools give the same, well, medical doctorate acronym. So for example, Manchester was MBCHB, but that's not the same. So you should know it and put your GMC number as well. Once that's all completed, that goes to the medical examiner, and they will discuss with you. Once you've come to an agreement, then they will complete the section at the bottom and then move on. Okay, so focusing in on section 1. So part A, 1A, is the disease and condition that led directly to death. Part 1B to D is a sequence of events going back in time, and part 2, and it's any sort of contributing factor. Actually, no, underlying root cause is probably a poor way of putting that, actually. So, for example, as the WHO defines, cause of death is the disease or injury or the underlying cause of death is whatever initiated the train of morbid events. So in this case, so for example, someone who has, let's think, so it could be something like smoking could be put in 1C. So the reason why I'm not going into too much information here is because this is very much specific to medical examiners, and I'm not an expert in it. But to think of an example, so smoking 1C, or asbestosis that contributed to emphysema or interstitial lung fibrosis that ended in respiratory failure or pneumonia, for example. And then you could put dementia as in part 2. So dementia contributing to repeated aspiration pneumonias that then led to the inevitable end product or end situation. Importantly, so section 2 is for any other significant conditions that contributed but not directly to the causal chain. This doesn't actually imply any disease that they had when they passed away, but anything that you think could have contributed. So this helps clarify the full picture. So I've actually added this section because I was flicking through and I thought it was quite interesting. But old age can be used as a cause of death, but is very specific to certain scenarios. So the patient must be over 80 years, under long-term care of the attending medical practitioner. So often in the case of a GP, where you may have patients dying in the community that haven't been seen by yourself over an extended period of time, you must have observed a gradual decline in the patient's function. You must not identify any disease or injury that could have contributed, and there cannot be any coroner referral concerns as expected. So as I mentioned earlier, I'm not an expert in the section on the cause of death. So if you want any further information, please go to the RC Path website, because they have a whole list of conditions that are appropriate to put in each section, as well as some guidance on any allusion to certain conditions that require referral to the coroner. So it's definitely a good link. So check that out. Yeah, so I think a small bit on communicating with families. I know that we discussed earlier that this is very much led by the medical examiner who will explore patient family concerns, but um, there's plenty of guidance on effective communication on GMC best medical practice. But just to touch upon a few, you should be aware that the families may not be aware of everything that may have gone on with the patient. And so explaining things simply as well as sensitively is important. Try to incorporate the patient's family wishes as well as possible. And and then point five, support the bereaved relatives and family via the medical examiner system. So they're very much more, better versed in communicating with families in these scenarios. Okay. So I know this has been quite text heavy and talking heavy, but we're getting towards the end, okay? So importantly, when to refer to a coroner. So as alluded to earlier, when there is no attending practitioner, as well as when the attending practitioner cannot establish the cause of death. So if it's unknown, or so it's essentially if it's unknown, and the medical examiner is also unable to confirm the cause of death as well. So if both of you are unable to, then it must be referred to a coroner. Now, the Notification of Deaths Regulation 2019 so there have been amendments made following the 2024 guidance on MCCDs on how and what should be referred to the coroner on top of points 1, 2, and 3. Okay. So essentially, any of these things that may more than minimally or negligibly or trivially cause the death or contributed to the death of the patient must be reported to the coroner. So specifically poisoning. So whether it be a benign substance or whether it be an active poison, whether it be taken accidentally or on purpose or given on purpose, they all must be referred to the coroner. Specifically, something like smoking or alcohol, unless you have a suspicion of acute poisoning of it. So someone who's coming without decompensated alcoholic liver failure, if there has been enough of a duration between onset and it's not the exact cause or direct cause of death, then it doesn't need to be included or referred to the coroner. So exposure to or contact with a toxic substance. The employment section that we spoke about earlier, so things like asbestosis, coal, all those substances that can cause respiratory disease. For example, working in a rubber factory that causes bladder cancer. The list is exhaustive. But if you have any suspicion of that, please refer it on. So control the drug or psychoactive substance. Important to know that that's not just illicit drug use, that is any legal drug use as well as legal highs as well must be reported to the coroner. Any violence, trauma or injury, as well as self-harm as well, and self-neglect. So I guess neglect, so self-neglect, let's start with neglect. So neglect being sort of the inadequate nourishment with food or liquid, adequate shelter or warmth, nourishment, liquid, shelter, warmth, and medical assessment, care, and treatment. So if any guardians or any persons taking care of someone who is not providing that would be deemed negligent, and that would be needed to be reported to the coroner. And anyone who is self-neglecting as well, those that live on their own, don't have the appropriate support, and have ended up in a situation where they don't receive any of those things that I just spoke about. Any treatment that's recently been given, or any recent surgical procedure must be highlighted. So if someone some orthopedic procedure becomes unwell and septic, you must mention that in the death certificate, as well as it must be referred to the coroner if it's within a specific time frame. And any injury or disease attributable to any employment held by the person during the person's lifetime. So yeah, there's some specific guidance on this. So you can all have a look at the 2019 guidance. It's very exhaustive, has all the stipulations within. We've covered most of this earlier. So when the cause of death is unknown and the medical practitioner as well as the attending practitioner doesn't know, and there is no attending practitioner available to sign, that's when it'll be referred to the coroner. Sometimes it's referred back if there's no cause to investigate. Oh yes, of course. The identity of the deceased person is unknown. So that's very important. Often people have just come to the country, or sometimes patients that are out of area, and there is no hospital record. That must be referred to the coroner as well. So lastly, just some general advice. So remember, this is a legal document, and patients as well as the courts will refer to it. Therefore, it must be as accurate and as legible as possible. Okay, you complete it. I mean, we haven't gone to electronic just yet, so those with bad handwriting, make sure that you take your time and write legibly. It also must be completed as soon as possible to avoid any further delays. So we spoke about how it's within the first 5 days, within 5 days that this should be completed. It's important to note that there are quite a lot of regional differences. So the majority of this lecture, we've actually focused on England and Wales. So the provisions supplied in the 2024 guidance focuses in on that. So the 28-day rule actually still exists in Northern Ireland. So be very wary of that. Access the MDU for any further information on that, as well as the government website. So, as we spoke, all deaths must be discussed with a medical examiner, if not referred to the coroner in England and Wales, and ensure you check all information possible. So, medical records, imaging, to check whether someone has an implantable device. Okay, lovely. So yeah, quick summary. So, clear, complete regional rules. And refer to any resources that are alluded to in the 2024 MCCD documentation. There are also quite a lot of YouTube videos that you can use for primary care as well as in hospital care that discusses how to complete these. And if in doubt, discuss with a senior, discuss with the medical examiner, and make sure that you are inputting the right information. Okay. So, just a few resources. Sorry, I actually realized I didn't make an end of the presentation slide, but that is the end of the presentation. So, the medical certificate. So look at the guidance, look at what your defence union has posted, as well as Geeky Medics have also provided a section on how to complete MCCDs according to the newest guidance. Yeah, lovely. Now I can put myself back on. So let me just, so thank you so much for listening in. We really hope that you can take something away from this. So I've just posted the feedback QR code. So if anyone is willing, please, we are striving to improve these sessions week on week. I believe the next lecture is the first week of September, I believe the 3rd, with Devesh, who will be covering advanced care planning. Have a look on CareerBook as well as Facebook for any event invites, okay? I'm just going to wait and have a look whether anything has been posted in the YouTube live link, okay? Just on, let's have a look. Oh, thank you, Dolman. Very much appreciate that. So yeah, please feel free to fill the QR code, tune in to the next session that will be in 2 weeks' time if you enjoyed that, and hope to see you again. At the moment, I can't see any comments, so I'll wait a little bit, okay? Also, after the YouTube live has been uploaded, you can comment on that and I can reply back according to the, well, whatever you posted. Okay, lovely. I'll keep that up for a minute or longer. Lovely. Okay. Well, thank you very much once again for attending, and I hope you have a good rest of the day. Hopefully you found some of this interesting or useful.